feet, you always ask yourself, where is the talus? So we've made some evaluation based on the methodology that I just presented to you. Now we're going to make some corrections. Now remember, wherever the talus is, it's there because of the navicular. Talo, navicular, calcaneal ligament. Talus, no muscle attachments. Talus, retrograde circulation. In fact, I read one study that said as little as 1 millimeter deviation right here at the sustentaculi tali will cause an unstable ankle. I don't know how you measure a millimeter. You know, you can't, really, I can't. So, but anyhow, these joints have to be stable. So, there's the talus. Now, before we correct the fibula, we have to correct the talus because of the articulation right here on the lateral anterior portion of the talus where the fibula articulates. Then we're going to correct the navicular. The navicular can only sublux by rotating medially and inferiorly. Out here in the cuboid. 50% of all ankle sprains cause a sublux to cuboid, which we must correct. And by the way, Doc, you feel that?
Yeah.
Yeah.
I do.
You don't feel it there, do you?
No, I don't.
No, what'd you do to your cuboid? Sprained an ankle?
I have no idea.
Yeah, okay.
I wouldn't have said that, but I sprained an ankle. I wouldn't have said that.
Okay. What would you have said?
I would have said I wear orthotics all the time. If
Okay.
I don't, I hurt. Yeah,
So here's the adjustments which we're going to do. Talus first, then the fibula, navicular, cuboid. When you adjust the talus, internally rotate to lock in the head of the femur. Because if you try and adjust out here where the femur is loose packed, you could cause problems with the teres ligament, which is the main blood supply to the head of the femur. That's Bo Jackson's problem, or was. So lock it in. Control movement by a firm grasp on the calcaneus. Find the dome of the talus. Is that sensitive?
No.
Okay. It will be in a minute. No.
Okay.
Contact it. Bring them into 4 degrees, okay, because that's what you want. Medially rotate, plantar flex, and now I'm going to bring her back into dorsiflexion right there. So there's your, a little better, huh?
Yeah.
There's your adjustment for an anterior talus. What do you think?
Yeah, that does feel better.
Yeah. There's a chiropractor I know who teaches a lot of extremity work. He has a very novel way to look at the feet. He said if the bone's up, push it down. If it's down, push it up. If it's in, push it out. If it's out, push it in. That's pretty simple. Okay, now after we correct the talus, let's do the fibula. Now the fibula is a dynamic bone that bears 15% of your body weight. The fibula must move posterior medial, anterior lateral, superior inferior. Now, a little bit about kinetic chain here. The most common of the hamstring muscles to strain is the biceps femoris. Biceps femoris attaches on the ischial tuberosity inferior rim of the pubes and then runs obliquely down and attaches on the head of the fibula. So if the fibula is locked anterior inferior, at the late swing phase of the running motion, the fibula will not move superiorly as the hamstring contracts eccentrically, which could cause the muscle to fail. Remember this in chiropractic, joint above, joint below. Everything we do, joint above, joint below. So let's fix the fibula. We're going to bring her up into knee flexion, dorsiflexion the foot, that loose packs. Stabilize the tibia, grab the head of the fibula, and before I adjust it, I'm going to mobilize it here. If I don't mobilize it here first, I may not get an adjustment. So we're moving it posterior, medial, anterior, lateral. You feel that moving?
Yeah.
Yeah. After we have mobilized that sufficiently, here's the adjustment. Stabilize the calcaneus with the thenar eminence. Bring her into inversion. Full inversion till you feel the anterior talofib ligament engage, right there. Bring her back into dorsiflexion with a firm contact on the anterior inferior fib. Back into dorsiflexion. Right there, I can feel the joint loose pack, and the line of drive is going to be posterior superior. So, plantar flex, full inversion, contact the anterior inferior aspect of the fib, right there, loose packs, and there's the adjustment. Now, when you have a person who truly has a sublux fibula, that will be a rather profound release. Now, we recheck that, if you would help me here, Doc. If you would palpate the head of the fibula right there. You feel that? Now you tell me if it's moving up and down. You feel it?
Yeah.
Let me check it. Yeah, you feel it moving up and down? Right there. Yeah, okay, that's what you want. So you put motion into an immobile area. Now positioning the fibula back where it belongs, posterior and superior, you tighten the anterior talofib ligament, which corrects chronic ankle instability. Okay? Now, let's do the navicular. Right there. You feel that?
Mm-hmm.
Now remember, the navicular can only sublux inferior and medially. So with that in mind, and this is going to be tough to do, Chris, because I don't want to block you out. So let's move you here. You got that? Can you see that? Contact the navicular and load it in the direction you want the correction to be. Now I'm also going to contact the medial cuneiform and the first metatarsal. I'm going to bring her into dorsiflexion with loose packs. I'm going to distract, and there's the adjustment. Loose pack, and it's almost like I'm wringing out the dishcloth. Loose pack, and there's the adjustment. You may or may not get an audible release. If it's severely subluxed and you make the correction, you will. Okay, not bad. What do you think?
That felt really good. That felt really good.
Cuboid. 50% of all inversion sprains, for obvious reasons, will cause a sublux cuboid. Cuboid comes superior and posterior. Contact the cuboid right there. I'm going to overlap, bring it into the loose pack position. We always adjust into a loose pack joint. We never adjust into a closed pack joint. Bring her back into dorsiflexion right there. Not bad, huh? Yeah, well, you really had that. That cuboid was sitting up now.
Mm-hmm.
You got to tell me.
Oh, that feels really different.
Yeah, well, you had an
Wow.
issue there.
Oh, yeah. That feels really different.
Now, here's part of your differential diagnosis. Tarsal tunnel syndrome versus plantar fasciitis, because the symptoms can appear to be similar. One way to differential diagnosis, bring the foot into full eversion, dorsiflex the great toe that stretches the medial plantar nerve under the tarsal tunnel. If it lights up along the medial plantar nerve, it's probably tarsal tunnel syndrome. So here's the treatment for tarsal tunnel syndrome. Locate the retinaculum right there. You feel that? Okay, that is a fibrous band underneath which, well, let's talk about all that goes through the tarsal tunnel. Flexor hallucis longus, tibialis posterior, flexor digitorum longus, and the posterior tibial nerve, which then bifurcates into the medial and lateral plantar nerve. So we're going to get in there, we're going to do a cross fiber myofascial release, and we're going to free that up. If you're into instrumentation, you want to use a Groston tool, you can use that. You have to be really sensitive with a Groston tool because you don't want to provoke some symptoms. I like using my fingers, I can feel a little bit more of it. Right there, you feel that.
That is a little tender.
Yeah, well, it's pretty tight. So anyhow, we're going to free that up, and that might be a 5-minute myofascial release. Now, a lot of the myofascial treatments that I do, I've also taught my CA, one CA to do. She has an undergraduate degree, and she also has a degree as a med tech, so she's pretty sharp. I had her do some papers, research articles on celiac, so she knew what the principle was behind it. And then I had her practice on me and other staff members for about a month until I figured she could do it proficiently. So I've taught her how to do that, so I don't have to spend an inordinate amount of time doing a myofascial release on a patient. So after I release that, here's the adjustment. Now, it is somewhat opposite to what we did with the navicular. If you remember the navicular, we took it into 4 degrees, dorsiflexed, and adjusted this way, right? Now, with tarsal tunnel, we're going to take her into plantar flexion and eversion to put tractioning on the nerve. And now, instead of adjusting it this way, we're going to adjust it this way. So contact the medial cuneiform, take it to the barrier, and right there is the adjustment for tarsal tunnel. I don't necessarily believe this study because it sounds a little bit of hyperbole. The one study, podiatric study, said with that technique you actually stretch the posterior tibial nerve 2 inches. That's a lot of stretch. I can take maybe 2 centimeters, and maybe it was in this print, but 2 inches, that'd be a lot. But there's your treatment for tarsal tunnel syndrome. So after we make the corrections, then we do our evaluation, the way I just presented in the PowerPoint. The key is posting the navicular to where you create a 4-degree angle. On average, the 4-degree angle allows the talus to glide. So you are creating normal kinematics at the tibial curl articulation or the tibial talar articulation. That creates normal biomechanics, prevents internal tibial rotation, eliminates medial knee joint pain or meniscal torsion, and has various very productive ramifications throughout the whole kinetic chain. Any questions on that? Now remember, we're going to send them home, patient home, with exercises. Rolling the ball, curling the towel, curl the towel, curling the towel. We're going to do exercises for the tibialis posterior. We're going to put her on some bands. I'm going to have her go into full plantar flexion and eversion. And now I want you to push up against my hand. Wait, only 30%.
Oh.
Push up, but push to the opposite ASIS. There you go. There's your tibialis posterior. Exercise, push up to the ipsilateral ASIS. There's your tibialis anterior. So here's what we do with rehab. I'm really ahead of myself now. Okay, push up, ipsilateral. That's contralateral. Or that's ipsilateral, I'm sorry. I told you I needed coffee.
You want
can edit this,
ipsilateral?
right?
Or
I
contra?
hope so.
You hope so, yeah. Okay. Let's try that again. Tibialis posterior, go up to the contralateral ASIS. Okay. Do it again. So we want to do 2 seconds up, 4 seconds down. 2 seconds up, 1 second hold, 4 seconds down with our rehabilitation exercises. One set to failure. That inroads the nervous system. That's all you need to do. You don't need multiple sets. Going to do the tibialis anterior, tibialis posterior, flexor hallucis longus, and mobilization techniques, and you can correct pronation. And that's a nice, by the way, dock. Why don't you sit up? That's a nice 4-degree angle there, isn't it?
Mm-hmm. It
That's
feels
what we
really
want.
good.
Okay. Any questions on that? Okay, you had to be out of here at 3?
Yes, thank you.
Okay.
Thank you
Pleasure,
so
my
much.
pleasure. Okay.
So what would you do with the orthotic then, after you've got all this done?
Well, don't go away. You're on candid camera. Okay, remember now, we make the orthotic. I have her in a standing position, and this is a good floor to do it on. Would you stand, please? Doc, I think I have my goniometer sitting over there. If somebody would grab that for me.
Don't move.
Okay. So with my marker, I'm going to mark the tibia, talus, medial cuneiform, tibia, talus, navicular, medial cuneiform. And I'm going to measure. Now I want her at about 4 degrees, so I'm going to set this to 4 degrees, and I'm going to lift the navicular right there until it lines up. Measure the height of the navicular. That tells me the amount of correction I need on the orthotic. So now I heat up the orthotic, and right where the apex of the orthotic meets the navicular, I post that according to my desired correction. I heat them up, correct, put them in the freezer, cool it down, then I put them in her feet. And then I have her do a 50% deep knee bend. There you go. If the heel stays on the orthotic, that's what I want. If the heel lifts off the orthotic, I go back and increase my correction, or maybe decrease, but I change the correction. Is that what you were asking? Okay.